Good morning, everyone. Thank you very much, Sam, for that wonderful introduction. It's a real honor to be here, and thank you all who have managed to make it through the weather. It makes me feel right at home. So I work at the Oxford Parkinson's Disease Centre, which carries out a wide variety of really exciting both clinical and laboratory-based research aimed at learning more about Parkinson's, identifying new therapies, and trialing different technologies. What I'm going to talk about today is some of the work that we've done at the Oxford Parkinson's Centre, and particularly an area of my own research, which is in impulse control behaviours as a consequence of some of the medications known as dopamine agonists. I'll start by giving a bit of an overview about what we do at OPDC, and then I'm going to talk about these impulse control behaviours in detail and explain what the relationship between dopamine and impulsivity is. An area which is already mentioned, and I know is of a lot of interest to people, is the links between impulsivity and creativity, which is something I've come across repeatedly in my work. And I'm going to talk about how there is a spectrum of impulsivity and what this means for people with Parkinson's. I'll finish up by summarizing some of our main points and talking about how we can take this work in the future. So as I said, there's two arms to the Oxford Parkinson's Disease Centre. The laboratory side, which works with both cell-based models and animal models of Parkinson's, is run by Professor Richard Wade-Martins. And these are areas where we're trialing potentially new therapies in Parkinson's on cell and animal-based models. And the clinical side, where I work, is known as the Oxford Discovery Project, and it's run by Professor Michelle Hu, who's been one of my mentors. We're funded by Parkinson's UK, which is a charitable organisation not unlike the Parkinson's Voice Project. And many of our research staff are provided by or funded by Dendron, who fund research in dementia and neurodegenerative conditions. The Oxford Parkinson's Discovery Project is a large cohort study that's been running since 2010. And we've recruited over 1,000 people with Parkinson's from what's known as the Thames Valley area in the United Kingdom. This is quite an intensive study where these people are followed up every 18 months, and we've now been running since 2010. We're in our second phase of the study, when we're already thinking ahead to 2020 for what's called OPDC3. In addition to over 1,000 people with Parkinson's, we have over 300 what we call healthy controls, usually spouses or friends without Parkinson's, and a number of people who are considered to be at risk of Parkinson's. So there are first-degree relatives, who obviously are at higher risk than the general population. And very interestingly, we have over 200 people with something called REM sleep behavior disorder, which I think there was a talk on here quite recently. RBD is thought to represent a prodromal form of Parkinson's. So with a cohort of this size, we have a unique opportunity to collect data on people who are likely to get Parkinson's, but before they have the symptoms of it. It's quite busy if you're involved in our study. We've recruited, as I said, over 1,000 people with Parkinson's. They come in every 18 months, and you spend at least 3 hours in the clinic. You're seen by a doctor and then by a nurse. There's extensive examinations and a number of surveys. And most people give blood tests for DNA and biomarker sampling. We also, there's some opt-in programs, so people have donated CSF, or cerebrospinal fluid, through lumbar puncture. People have given skin biopsies, which is really interesting because skin biopsies can be developed into stem cells, which can then be grown into dopaminergic brain neurons, and gives us the opportunity to actually run experiments in the lab on real dopaminergic neurons from people in our study. There's also imaging studies, and people undergo CT and MRI scans. There are 4 main aims of the Discovery Cohort. And I've already spoken about how we work very closely with our colleagues in the lab to allow translation from bench to bedside and back again. As I said, we have a prodromal cohort of people with RBD, and this is one of the largest cohorts of that type in Europe. And having a cohort this size of this many people with Parkinson's allows us to validate certain technologies and test out new technologies on a wide scale. Some things that we've done are looking at new imaging technologies, and we're very interested in wearable technologies. We have a smartphone app that all of our participants use for at least a week, every 18 months, and this monitors the symptoms of Parkinson's and actually can grade the severity, or at least that's the intention, and can even sensitively identify people not just with Parkinson's, but also with RBD, simply on listening to a 30-second recording of their voice, which of course would be very relevant to the Parkinson's Voice Project. My work comes under the heading of stratifying PD. And what this means is we're using the cohort at Discovery to learn as much as we can about the clinical signs and symptoms of Parkinson's. Some of the work that's come out of this was a recent paper by Michael Lawton, where we identified 5 different subsets, clinical subsets of Parkinson's, of people who either progress at different rates or present with slightly different symptoms. My work, as I said, is looking primarily at some of the medications that we already have in Parkinson's. And I'm particularly interested in the adverse effects or the unwanted effects of these medications. The reason that I am, I think, is that these adverse effects obviously have a significant effect on people, and I want to know who is most affected by them and what type of effects they experience. I also think this actually tells us a lot about the underlying processes in Parkinson's. And so that's some of the work that I'm going to talk about today. And this is what all of my work comes down to. Does anybody know what this molecule is? This is dopamine, right? And this is what Parkinson's and what Parkinson's therapies are all about. Dopamine is a molecule released in the brain from what are known as synapses that look like this. And synapses are connections between nerves or neurons in the brain. And when dopamine is released from one neuron and attaches onto little receptors on the other side of the synapse, then that sends electrical signals in the brain that can help control our movement. Parkinson's, in its most simple explanation, is a neurodegenerative condition in which these neurons disappear, and so we don't have enough dopamine. Perhaps even more simple is that then to treat the symptoms of Parkinson's, we need to just replace the effect of dopamine. You notice I've said it's simple. Of course, that's not the case. These are some of the medications that I'm going to talk about today. Obviously, the gold standard treatment is levodopa, but many people will be familiar with these dopamine agonists, such as ropinirole or Requip, pramipexole or mirapexin, and the rotigotine patch, Nupro. Apomorphine is an injectable medication, which is actually a very strong dopamine agonist. It's typically only used in the later stages of Parkinson's. And as I said, it's not that simple, because with any treatment, like anything we do in medicine, we have to constantly balance the benefits of symptom relief with the risks of unwanted effects. So what kind of unwanted effects do we see with dopamine agonists? I think the best way to illustrate that is to go through the history of these medications and how we learned about these adverse effects. Because, as I said, levodopa has been around for a very long time, but these particular dopamine agonists have only really come into use since the early 90s. And when they did, everyone thought this was great. Levodopa obviously has a lot of its own side effects. Some of my own research is in that area as well. And people were relieved to have an alternative therapy. But actually, within a few years, people started to notice that something was going wrong. So by the year 2000, some studies started to be published on this. This group in Spain looked at their group of several hundred people with Parkinson's, and what they noticed was that there seemed to be a disproportionate number of that population with problems of pathological gambling. So this is gambling that's causing a proper effect on their life, often losing money or damaging relationships. Released in the same year was a groundbreaking paper by Giovannoni where he identified something called hedonistic homeostatic dysregulation in Parkinson's. Okay, bit of a mouthful. Basically, this is a term that existed before but hadn't been used in Parkinson's. And what it had been used to describe before was actually drug abuse and drug addiction. What Giovannoni described were 15 people who seemed to be abusing their levodopa and abusing their medications to such an effect that they were actually acting addicted to them. So they were taking what he describes as, and what this homeostatic dysregulation is that people were taking their medications not just to sort of partly to get a high, which sometimes people can experience with levodopa or with dopamine agonists, but more that as the medication wore off, they experienced something called dysphoria, where they were in their Parkinson's symptoms came back. It made them very anxious, and they wanted to avoid this, so they started taking higher and higher doses of their levodopa. What was interesting is that these people exhibited various other behaviors. He again described that many of them began gambling and were losing a lot of money. Some of them were overeating and gaining weight. Some of them had had affairs and their relationships had fallen apart. And a couple actually had to be admitted to psychiatric institutions with symptoms of mania or psychosis. So this started to worry Giovannone, and it started to worry the whole Parkinson's community. What both these studies noticed, that people seemed to gamble more and exhibit these behaviors when they were in the on phase of their medications. What wasn't quite clear was what contribution Parkinson's itself had and which medications were most causative. Because while most people were abusing levodopa, all the patients, or most of the patients in Giovannone's study, had only started doing this when they were started on apomorphine, which was that potent dopamine agonist that is given by injection. Over the next few years, people started to study these more and more, and we started to really realize what they were. So these became known as impulse control disorders. And quickly, people began to realize that these were not so much due to levodopa, though they can be seen with levodopa, but that the much greater offense was the dopamine agonist. And this was finally sort of confirmed by a couple of studies by Weintraub in 2006 and eventually 2010, where they looked at over 3,000 people with Parkinson's to see exactly how common these impulse control disorders were. What he found was that at least 15% of people seemed to experience these disorders at some point. And not just that, but that the chance of having an impulse control disorder was 2 to 3 times more likely if you were taking a dopamine agonist such as ropinirole or pramipexole. There were a few more studies where we learned a lot more. One was that Antonini looked at a group of people with Parkinson's who were yet to take any medication at all to see if any of them had ICDs or impulse control disorders. And yes, some of them did, but importantly, impulse control disorders are not specific to Parkinson's. Plenty of other people gamble without having these medications. And so the likelihood of having this if you were drug naive in Parkinson's was just as likely as as somebody without Parkinson's. So that sort of confirmed that it's not the disorder, it is the drug. As people understood more about these disorders, they began to recognize more of them. So now we also, and I'm going to go through the different types of disorders, but we began to include things like punding, which is a sort of repetitive stereotype behavior, or hobbyism, which involves people becoming excessively interested in hobbies that they find interesting. Of course, when the scientific community starts to get really interested in something like this, so does the press. And perhaps it's not necessarily unwarranted, because in the extreme form, these impulse control disorders were found to be very, very dangerous. People were losing huge amounts of money, people's marriages had fallen apart, and actually, once this was properly attributed to the dopamine agonist, there were payouts by the drug companies in some instances. So why are these things happening with dopamine agonists? To understand that, we've got to look at exactly what a dopamine agonist is. So I've already spoken about how we want to replace the effect of dopamine in the synapse in the brain. And what a dopamine agonist does is it acts as a dopamine mimic. So it activates the dopamine receptors in the brain by binding to them directly. Levodopa is different. Levodopa actually gets turned into dopamine and released from the neurons in the brain. But this acts directly on the receptors. And there are different types of receptors in different parts of the brain, and they can have very different functions. So, for instance, the receptors D1 and D2 exist in the dorsal striatum of the basal ganglia, which is known as the motor circuit. And this is the area most affected by Parkinson's. If your motor circuit is affected, then you will start to have symptoms of tremor and bradykinesia. And if you activate the D1 and D2 receptors in that area, you can relieve the symptoms of Parkinson's. However, there's also a receptor called D3. It's in the basal ganglia as well, but in an area known as the ventral striatum, or the reward circuit. And the reward circuit, I'm going to talk about a bit more in a moment, but it's what drives any reward-seeking behavior, but also drives impulsivity and addiction. And not only do dopamine agonists bind to D3 receptors and activate signals in this part of the brain, but it's possible that they prefer D3 to D1 and D2, which is why we see these more with dopamine agonists than we do with levodopa. So what's the point of the reward circuit? Why do we have one? Well, the reward circuit is the part of our brain that encourages us to do any activity that we find rewarding or pleasurable. So for instance, I like chocolate. And how do I know? I know I like chocolate because of my reward system. Because if I eat a bar of chocolate, it activates a part of my brain known as the ventral tegmental area, which is the start of my reward circuit. The ventral tegmental area has dopaminergic neurons to the nucleus accumbens and throughout the rest of the brain through an area called the prefrontal cortex. The areas aren't important. What's important to realize is that when your reward circuit activates, or when you have a pleasurable stimulus, the dopamine neurons start firing and releasing dopamine in these parts of the brain. But what if you don't eat the bar of chocolate? In fact, what if you just looked at it? Or if you just thought about chocolate? And what we notice is that in those circumstances, exactly the same thing happens and the reward circuit gets activated. So in the past, everyone called dopamine the sort of the happy molecule. It's what we get when we do something that makes us happy. But actually, dopamine is released not just in response to a stimulus, but in anticipation of one. So if we think about chocolate and our reward circuit goes off, what do? Well, we go and eat the chocolate, or we go and find chocolate. If then you're taking a dopamine agonist, and even without any stimulus at all, your dopamine agonist activates your reward system, then what's going to happen? You're going to go and eat chocolate without even thinking about it, okay? So what these medications do is that they activate your reward system, and these give you impulses. And these impulses can be very strong, so strong that you're unable to resist them or control them, even if you know that it's something you shouldn't be doing, and even if it starts to cause you harm. And these are what's known as impulse control behaviors. Please excuse my spelling of behavior. So an impulse control behavior is a problem in the self-control of emotion and behavior. So this difficulty controlling your response to emotions. When they're very extreme, they're known as impulse control disorders, and that's what we call syndromal behaviors. These are an important distinction I'm going to make, because what we feel the literature has not recognized up till now is that not everybody meets the diagnostic criteria for a true disorder. But many people experience these behaviors in some shape or form and in a way that may be affecting them, and we want to learn more about that. An impulse control disorder persists even when it's causing harm. And the problem is that when it causes harm, this causes stress and anxiety, and what that actually does is drive people to seek further reward, and it gets into a vicious cycle. In the same way that the reason people were abusing their dopamine medications in Giovannoni's study was not so much because they wanted the high, they were just trying to get away from the low. These are some of the examples of impulse control behaviors, and I'm going to go through them in a bit more detail so people understand exactly what they are and some of the things that they might notice if they're on these medications. The ones I'm going to go through the strict diagnostic criteria of each of these disorders, which tend to describe a severe end of the spectrum, but then we'll talk about how these can exist in a milder form. Pathological gambling is definitely the most infamous of the impulse control disorders. It's defined in the DSM, which is a psychiatric manual for diagnosis. And it basically involves people gambling more and more money to achieve the same amount of excitement. You don't necessarily need to win. It's the excitement of gambling in a lot of cases that drives this behavior. And people tend to get quite irritated if they're challenged on this, or if they try and cut down. And usually they've tried unsuccessfully on numerous occasions to stop their gambling. Not just are people gambling, but also they can't stop thinking about it. So even when you're not gambling, these thoughts occupy your mind, and this is true of all the impulse control behaviors. And being distressed or upset encourages further gambling behavior, and that gets you into this vicious cycle. Obviously, and like I've said, this is not specific to Parkinson's. People will lie to conceal the amount of gambling. People will borrow money and get into a lot of debt, and this can have a significant effect on their relationship and on their job. To have a true diagnosis of pathological gambling, you need to tick a certain number of these boxes, and you need to have at least one of the last two, in that you are either borrowing money or it's affected a relationship. If you only have some of these, it's known as problem gambling. Binge eating, again, is defined in the diagnostic the DSM, because it's an eating disorder, and this can occur on dopamine agonists. The hallmark of it is that people eat what other people would consider an excessive amount of food in a very short time. And it's usually a single food group, so people eat a whole box of chocolates or an entire loaf of bread. And once they start eating, they feel they lose control and can't stop before they get to the end, and then may go and look for more food. People eat very quickly. They eat when they're already full, or when they don't even feel hungry. And as soon as they finish, this usually makes them feel very embarrassed. And all this does is make them dysphoric and encourage the behavior more. Hypersexuality is an incredibly difficult impulse control behavior to manage. And I'm going to talk about it quite frankly, because I think there needs to be less taboo around this particular behavior. Quite simply, hypersexuality is a maladaptive preoccupation with sexual thoughts. And what it tends to be is a change from previous. So what we look for in Parkinson's is that people's behaviors or their interests have changed from before. Partners might notice that the person with Parkinson's is requesting sex a lot more frequently, or perhaps at inappropriate times. And people with Parkinson's particularly describe having sexual thoughts that they just can't get out of their head. Obviously, people may become more promiscuous, or they may start engaging in telephone sex lines, or nowadays online dating, as obvious, or pornography have become a lot more common. People can, it's not common, but people can experience paraphilias, which are would be considered unusual sexual interests. And unfortunately, and remember that this is a side effect of a medication, and it is very, very rare, but people have had fantasies or even engaged in behavior that would be considered illegal. Not surprisingly, again, this causes a lot of distress. It can be very time-consuming, and all that does is encourage the behavior further. Compulsive shopping is exactly what it says on the tin. You definitely don't need to have Parkinson's to experience this particular behavior. But the mainstay of it is again, this loss of control. People are worried that they can't even walk past a shop window, and they'll go and spend an excessive amount on something that they don't need, or will buy lots of the same thing. And the loss of money and the distress drives the behavior further. These two impulse control behaviors are interesting because they're a bit more specific to Parkinson's. All those other ones can obviously do exist in the normal population. Dopamine dysregulation is what we were previously calling homeostatic hedonistic dysregulation, and this is abuse of dopaminergic medications. So I've already described how people will take more and more medications to relieve their off-period dysphoria. They will often hoard medications, and this can be very difficult because trying to come off the medication is complicated by the fact that people actually go into a withdrawal state, and so it's very, very challenging if people are experiencing this in the extreme. It can often resemble what's known as mania or hypomania, which is one end of, mania is typically described as one end of the bipolar spectrum, where people are full of energy, have racing thoughts, and reduced need for sleep. And that's really interesting because it's something that I'm going to come back to. Punding and hobbyism are slightly different, but are defined in the same way because they're both an intense fascination with repetitive, excessive, and non-goal-oriented behaviors. Punding is what some people would consider an obsessive-compulsive type behavior, where people are repeatedly cleaning and tidying objects, and it's a very simple motor activity that's repeated over and over again. Hobbyism is more complex than that. It's an intense fascination with a hobby or an interest, so be it reading, writing, or gardening, or artwork, as we'll come on to. And one thing that we're seeing a lot of now is excessive computer use and smartphone games, quite likely because that's this sort of a hybrid between the two of these behaviors, because it has the repetitive actions of punding with sort of a more goal and reward that is seen with hobbyism. So those are the disorders. Those are the adverse effects that can come out of dopamine and from dopamine agonists. But impulsivity, so those are all impulse control disorders, but impulsivity is not always a bad thing. We have a reward system for a reason, and we have impulsivity for a reason. And in fact, impulsivity can be quite productive. I've spoken to a lot of people with impulse control behaviors, and one thing I've come across is people who, when they start their dopamine agonists, or maybe even their levodopa, experience a huge rush in creative drive. This particular lady was an artist long before she had Parkinson's, but it described when she started her treatment just being overwhelmed with creative ideas, that she couldn't stop one, or she couldn't finish one before she had another 100 ideas. She started experimenting with new media, and a very similar case is a lady, she experienced the same thing and began experimenting with new colors. Her artwork became more abstract, and they've both produced these really, really beautiful works of art and have been very kind in letting me show you today. I thought this was really, really interesting when I came across it, and I wanted to look into this more, see exactly, has anybody else described this, and what can it tell us, not just about impulsivity, or not just about Parkinson's, but what does it tell us about impulsivity generally? And this is certainly something that's been recognized. And I know that a lot of people hear this, but some really beautiful artwork around the halls here. So a lot of people may have experienced this. There are lots of cases of people who become creative in the course of their Parkinson's treatment. Probably the biggest study I've come across was by Lome, which he described 22 different people. And it's not just art. People have become poets or novelists or musicians. And the main things that we've learned from all these studies is that, yes, creativity can occur as a result of dopamine replacement therapy. And also it doesn't necessarily have to co-occur with an impulse control disorder. Now, one of the artists who I showed you did have to stop her medications because she was experiencing other impulse control disorders, but one didn't, and she remains on her dopamine agonist today and has managed to control her behavior very well. In fact, some studies have suggested that just because you become creative, it does not make you any more likely to have an impulse control disorder. However, I think that's very debatable, because what these studies did recognize was that some people became so creative that it started to cause a problem. So this lady here she became hugely artistic, she stopped sleeping, she never stopped doing her artwork, and she began painting every available surface in the house. It's beautiful, it's impractical, and she had to come off her dopamine agonist. What probably wasn't recognized in this study is that we personally feel that this probably represents an impulse control disorder in the form of hobbyism. Hobbyism is a fairly new addition to this field, so it may not have been classed as that, because they did recognize that creativity in extreme form can resemble mania in the same way that people often become manic not often, but can become manic with dopamine dysregulation syndrome. Importantly, if you stop the dopamine agonist, the creativity tends to go away. It doesn't necessarily go away completely. And one of the artists that I showed you, when she stopped her dopamine agonist, she still feels she has a very different creative drive to what she had before her diagnosis, but it's nothing compared to what it was when she was on the medications. So what does this tell us about impulsivity? Well, if you think about it, impulsivity and creativity, I would argue, are very similar processes. because impulsivity is all about a reward seeking, okay? It's driving you towards something that should be pleasurable or rewarding. Creativity, the definitions kind of vary, but it's essentially somebody driving to create something or produce something new and exciting that they find pleasurable and they hope pleasures somebody else, right? So both of them are, in essence, a reward-seeking behavior. So it seems very likely that creativity is driven by our reward circuit, and so it's driven by dopamine. What's interesting is that this tells us this can be applied not just to Parkinson's, but to creativity throughout the rest of the world. If excess dopamine causes creativity, it doesn't just have to come from a dopamine agonist. There are all sorts of other things that give you dopamine. I'm not recommending this. Before I get fired, cocaine is not a treatment for Parkinson's. But what it does give you is a lot of dopamine. And so reward behaviors are also addictive behaviors, and it's the mesolimbic system, the reward circuit, that drives drug addiction. What I probably don't need to convince you of is that if you look throughout history, and I'm sure plenty of us could give examples, there's often been a co-occurrence of people who abuse illicit drugs, but are also very creative. The one that I would like to draw your attention to particularly is Ernest Hemingway, because Ernest Hemingway almost certainly was a drug addict. He particularly liked absinthe, which was a hallucinogenic, and he was certainly an impulsive person. He was a womanizer, and he was very creative. So it seems possible that if people are getting dopamine from illicit drug use, then that could potentially drive creativity. But the reason Ernest Hemingway is interesting is that he probably didn't just get his dopamine from drugs, but it's now recognized that he probably had bipolar affective disorder. And as I said, one end of the bipolar spectrum is mania, and mania is pretty well recognized now is driven by excessive dopamine and excessive activation of your reward circuit. So dopamine can come from other sources. I should say that I don't think you don't need to be a drug addict, or you don't need to be bipolar to be creative. And in fact, what studies have shown is that really, when these things occur in excess, so if you have true mania, it probably is actually counterproductive. But what it at least suggests is that there's a strong role for dopamine and overactivation of dopamine in both creativity and impulsivity. But let's take this back to Parkinson's, because now what can we learn from this? Well, it tells us that impulsivity can occur on a spectrum. It doesn't have to be harmful. And this is something that at OPDC that we feel has not been properly recognized in the literature. Studies have shown that as many as 15% of people seem to experience impulse control disorders. But the way they diagnosed that was that people either had a true disorder or they didn't. Very often they use those strict diagnostic criteria that I showed you, where you have to tick at least 4 or 5 of the boxes before it's considered a disorder. So what they don't look at is subsyndromal disorders, where people are maybe spending a bit more money than they used to, or eating slightly differently, but it's not really a problem. And what that neglects is the severity of these behaviors. It's completely binary. You have a disorder or you don't. You need to come off your medication or you don't, which is obviously not the true, because we know that not everybody is at this end of the spectrum. So we set out to look into this at OPDC. And this study was led by Fad Beg, and our expert in impulsivity is Dr. David Okai, who's a neuropsychiatrist at Oxford. And what Dr. Okai has done is he's developed something called the Parkinson's Impulse Control Scale, where we try and grade the severity of these behaviors on a simple sort of 1 to 12 scale. It uses 2 measures. The first is intensity and impact. Intensity is basically how much time, or in some cases how much money, you're spending on a behavior. But the impact is how that actually affects your activities of daily life, or how it affects the people around you. And then we multiply those 2 scores by each other. And that's really important, because what it recognizes is that people could have behaviors of equal intensity, but a very different impact. For somebody to go out and buy a brand new car for $10,000 may not be a problem or even be that unusual if you have that money to spend. But for other people, that could completely use up all their life savings. So it's really important to recognize what the true impact is on that person, and that's why Dr. Okai has developed the PICs. What we wanted to do with our study was we wanted to answer a few different questions. Again, we wanted to look at exactly how common these behaviors are, looking not just at the strictly diagnosed impulse control disorders, but the whole spectrum of impulse control behaviors, both syndromal and subsyndromal. We then wanted to try and use the PICs to grade the severity of any of those behaviors on a scale. And then because the Discovery Project is a longitudinal study and we follow people up over a long period of time, we were able to interview them not just at the first interview, but again 1 or 2 years later to see how these behaviors changed over time. And longitudinal study is really the cornerstone of what we do at OPDC, because Parkinson's is a chronic condition. So we think that it's just not helpful to only ever look at a snapshot in time of something in Parkinson's. We need to know how that progresses. So what we did was anybody who is involved in this discovery study every 18 months answers a very simple questionnaire called the QIP, or the Questionnaire on Impulsivity in Parkinson's. So 921 answered this questionnaire, and the questionnaire asks 10 simple questions, which are basically, do you think you are spending too much money? Do you think about money? Do you think about eating? And so on. And if you answered yes to any one of those questions, we sent you a letter, and we asked you if you would either come in or be willing to participate in a phone interview so that we could go into a lot more depth, learn exactly what this behavior is, and grade it using the PICs. In total, of that 920, there were 195 people who answered yes to at least one of the questions in their most recent questionnaire. 88 of those then wrote back and became involved in the interviews. So these are just some of the most simple results we have. As I said, there were 88 people who answered yes to one question, and 39, once we sort of got into it, had a true impulse control behavior. The reason we didn't see it in all 88 is that the questionnaire is very non-specific. Lots of people will say yes, that they think about, if they're asked if they think about food too much. But what we really look for is something that is in some way excessive or has changed since you started on your dopaminergic medications, because we were looking specifically at Parkinson's ICB, not just ICB in general. Of those 39, 10 met those strict diagnostic criteria for an impulse control disorder that I described to you. The other 29 were all subsyndromal. They definitely had an impulse control behavior, but it just didn't tick all those boxes. Interestingly, 12 of that 29, sorry, I know there's a lot of numbers, but 12 of those 29 had, we suspect, had a true impulse control disorder in the past. So when we asked about gambling, they say, well, no, actually, my gambling's kind of under control now, but you know what, I used to, and I had to change my medications. Interestingly, these people, the disorder had not completely gone away. They were now subsyndromal, so essentially in remission from their impulse control disorder, but it never went away entirely. And this is something that people describe again and again, that even when you come off your medications, you do feel more impulsive than you did before. So in total, we had 20 people who at some point would have had a true impulse control disorder. We were able to extrapolate this data and we expect that in and around 10% of our total population have some kind of impulse control behavior. That, and roughly 1 in 4 have an impulse control disorder. That is a lot less than what some studies have said, probably for a number of reasons. Many studies just use the QIP or sort of a screening questionnaire to diagnose these, so that's probably going to pick up things that aren't true impulse control behaviors. But also we're now sort of nearly 20 years down the line of using these medications, and clinicians and people with Parkinson's and caregivers are all becoming a lot more aware. So it's entirely possible that the incidence of these are going down. As I said, anybody who had an impulse control behavior, so those 39 people, were interviewed again about a year or two later, and 28 people participated in that interview. So now that we've identified who gets impulse control behaviors, we can start looking at why they do and what makes them more likely. Because lots of people take dopamine agonists, but not everybody becomes impulsive. So we want to know what's putting people at highest risk of that, so we can know how to use these medications more safely and more efficiently. So in our study, at least, not surprisingly, any dopamine agonist use made you a lot more likely to become impulsive, and that's now very, very well recognized. People who had more severe Parkinson's symptoms were more likely to become impulsive. So we use something called the UPDRS, the MDS UPDRS, where we grade people's symptoms on both clinical examination and on a patient-reported questionnaire. And the people who score higher on that were more likely to become impulsive. Also, rather unfortunately, if you are prone to other adverse effects, such as dyskinesia or motor fluctuations, you may also be more likely to become impulsive. And people who experience orthostatic hypotension, which is a drop in blood pressure related not only to Parkinson's, but also to the medication, it may make you more likely to become impulsive as well. Apathy is interesting. Apathy is considered to be a non-motor symptom of Parkinson's, and it's essentially, I mean, we all know what apathy is. It's that sort of lack of interest or lack of energy in doing something we would normally enjoy. And apathy can occur in Parkinson's, and it's always been thought that that's been related to the reward system because of loss of dopamine there. Essentially, apathy should be considered the opposite of impulsivity, but actually people who describe apathy, and we have an apathy rating scale, are still more likely to experience an impulse control behavior. Now, we don't know why this is, but our speculation is that if you are apathetic, that it suggests a change in your reward system. So the fact that there's any change there at all may make you more prone to impulsivity when you take a dopamine agonist. Not something that had been recognized before was that people with fewer years in formal education seem to be prone to these slightly. That could be by chance. We don't know the true cause of that, but it also may be that people who have lower income or less support at home are more subject to impact from their impulse control behaviors. And something that was not true in the discovery cohort, but has been suggested elsewhere, is that men seem to be more prone to impulse control disorders. That's in the general population as well as in Parkinson's. And that the younger you are, and the younger you are when your Parkinson's starts, the more likely you are to suffer an impulse control behavior. But like I said, that wasn't actually true in our study. So it may be that when you account for all the other variables, that's not the case. I spoke about the sort of difference between syndromal and subsyndromal. So a true disorder and then kind of simmering below the surface. And this is what we're really, really very interested in. We want to try and make people more aware of, because these syndromal and subsyndromal do seem to behave slightly differently. Now, this data here, we had very small numbers by the end of the study, so this is not a statistically significant result. But what we felt was that when people were describing a clear impulse control disorder, it tended to happen quite quickly. It's usually within about a year of starting your dopamine agonist. But the people who were subsyndromal and were just experiencing some form of impulse control behavior described a much longer onset between starting medications and the onset of impulsivity. So it's sort of more insidious and creeps up over time before anyone notices. And this does seem to, there's certainly a suggestion of this in the data, because this is the length of time between starting medication and start of impulsivity in the subsyndromal and the syndromal. And that's something we'd definitely like to look at on a larger scale to see if that's a true result. These are the behaviors that people experience in the discovery cohort. So black is syndromal and gray is subsyndromal. Far and away the most common is overeating. Hobbyism, shopping, and hypersexuality are all quite common as well. Interestingly, we had very few gamblers. The people who did gamble had a true pathological gambling disorder and were at the severe end of the spectrum. This is quite different to what some studies have said. A lot of studies have said that gambling is the most common. the reasons for that change may be, first of all, I think we are a lot more aware of gambling. It's certainly the one that has been in the press the most. And if you have any history of gambling at all, it's very unlikely that you will be started on a dopamine agonist. So the incidence of this may be dropping. But also, if somebody has a true severe pathological gambling disorder, they're probably going to be a lot less likely to participate in interviews on this. So it may be a sort of skewing of the data. I should explain when these in the pairs of columns, the one on the left is the first interview and on the right is the second. And as I said, everybody was graded on a PIC scale, and this is the types of severities we saw. So there are some people at the severe end of the spectrum. Okay, these people were spending a lot of money, or in some cases had marriages break up, and these were very, very clear impulse control disorders. Now, a lot of people exist down this end of the spectrum. So if you score a 1 or a 2 particularly, I mean, a 3 probably implies you're having some kind of effect. You're either doing this a lot or it's impacting you slightly. But a score of 1 or 2 is usually not harmful at all. And this is when people are usually just eating a little bit more chocolate than they used to, but it's completely under control and their caregivers are aware. So that's very common. What we don't know is what that really means down the line. Is this something that's going to develop into a disorder? Is it just going to stay the way it is? And that's something we want to learn. So sort of aiming towards that was our interview 2 years later, where we were able to grade everybody's severity again and see if they were going up or down. Now, as you can see, they sort of went everywhere. But about half of people did show an improvement in their severity score between interview 1 and interview 2. So that was encouraging. However, nearly 30% of people did get worse. And then some people stayed exactly where they were. There were 5 people who did not meet the diagnostic criteria for an ICD at their first interview, but did at their second. And this sort of describes that in a bit more detail. So at our first interview, remember this was out of 29 people, or 28, sorry, 7 had a true Parkinson's impulse control disorder at the first interview. 8 had one at the second, excuse me. But only 3 of these were the same person. So of those ICDs, 1 went away completely. 3 became subsyndromal, so sort of went into remission, and 3 maintained. Interestingly, this group of people here are those who had previously had an impulse control disorder, but were subsyndromal or in remission at their first interview. And 2 of them went back and relapsed into a PD, impulse control disorder. Basically, what this showed us is that there's a lot of change going on. And we wanted to know what was driving that change. If we can identify what makes these behaviors better and worse, we can learn how to manage them better. So the most obvious thing was to ask was, is it the medication? Is that what's changing? Because at our first interview, of those 28 people, 23 were taking a dopamine agonist. Now, anybody who had a true impulse control disorder, we did notify their neurology team and their general practitioner so that they were made aware of it. But actually, between the first and second interview, only 1 person stopped their dopamine agonist. There were a wide range of reasons for this. First of all, it's quite a short period of time to come off a medication. But some people actually did try and stop their medication and found it too difficult because they had quite significant withdrawal from it. In other cases, they saw their neurologist and it was decided that on the balance of risk and benefit, that the behavior wasn't so severe that it outweighed the benefit that they were getting in their symptoms. They would just keep an eye on it. And that's completely reasonable. 5 people weren't on their dopamine agonist at the first interview, but 4 of these 5 had taken one in the past. So what that basically means is that in total, of the 28 people, there are 5 who have at some point gone from taking a DA to not taking one. And of those 5, 4 did show improvement in their severity scores between the 2 interviews. 1 actually got worse. And unfortunately, what the literature does tend to suggest is that if you stop your dopamine agonist due to an impulse control disorder, you have at least a 75% chance of that disorder getting better, but there are cases where it can persist. But this isn't enough to explain all that change and all those lines going everywhere. If everybody in the study had stopped their dopamine agonists, I'm convinced that we would have seen the severities plummet, but they didn't. So there must have been something else. So we thought, well, maybe it's the dose. And it's not that either. There was a lot of change in dose. Some people increased, some people decreased, some people stayed the same. And as I said, some people's behaviors got better, some of them got worse, and again, some of them stayed the same, but there wasn't any correlation between the two. This is an important thing to know about impulse control behaviors, because actually, all the literature suggests that it is not a dose-related response. Some people become impulsive on DAs and some don't. You don't need to be taking very much of the medication for it to happen. And if you try and reduce your dose, it rarely actually has the effect you want in improving the behavior. You do need to stop the medication completely. So it's not the type of medication and it's not the dose. So what is it? And the answer is, in a study this small, we don't really know. It's very difficult to find exactly from these sorts of numbers what's driving this kind of change. But at this point, we've spoken to a lot of people for a long time about those behaviors, and it's really interesting just to hear what people think improved their severity or why their behavior has gotten worse. Because what people describe is this really strong role for kind of things that are going on in their life and their support mechanisms at home. So for instance, I had somebody who had previously had an impulse control disorder, and it had gotten better when she stopped her dopamine agonist. But unfortunately, she had a death in the family shortly before our second interview, and she had started eating a bit more again. And that was just a response to that stress. And actually, it fit, again, the criteria for a disorder. I've also had somebody describe that their behavior has gotten much better, not because it was any less intense, but because of the support networks at home. So a gentleman who had quite strong punding behaviors and would spend an hour or so a day focusing on these kind of stereotype behaviors. This was causing a lot of stress at home. His wife was getting concerned, and if she mentioned it to him, that he would become quite irritated, and it was putting strain on their relationship. But by the time I spoke to them again, they'd sort of learned what this was. They'd realized it was a consequence of the medication. And so they were learning just to sort of deal with it. He would do this for a couple of hours of the day, and she would leave him alone. And then he'd come back, and it wasn't a problem anymore. So it was no longer an impulse control disorder. So what this suggests is that there's a lot of psychological input to impulsivity. And what I'm going to try and show you now is, I've already shown you the neurological model for impulsivity in the picture of the brain, but we'll also describe the psychological model, because this is what leads us towards ways that we can actually treat and manage impulse control behaviors. Basically, anybody can become impulsive. You don't have to have Parkinson's, you don't need to be on medication. It can happen to absolutely everybody, and there are different things that feed into it and lead you to become impulsive. Of course, one thing could be that you have Parkinson's and you're put on a dopamine agonist. But it doesn't necessarily have to be that. And there's also other predisposing factors. So you may just be an impulsive person, or you may have a past history of impulse control behaviors. So this is why, if anybody has a history of gambling, or even if somebody has a strong family history of gambling or drug addiction or alcoholism, we would be a lot more reluctant to start people on a dopamine agonist, because that risk probably outweighs that benefit. You then can have other triggers, and so those things are in the past, but that you can have current triggers. So any of your current behavior or something that's going on in your life at the moment. So the amount of money you have, and the amount of time you have. If you're retired and you have a good pension, then actually you can spend your entire day working in your garden, even if it's an impulse control behavior. But if you're working and you don't have a high income, then that could cause a problem. The coping responses are really, really important, because impulsivity is a stress response. And if your coping mechanism is to eat or to drink alcohol or to go and spend money, then then that's going to lead to an impulse control disorder. And not just that, but that disorder is going to cause more problems, lead to dysphoria, and it's going to get you into this vicious cycle. So this is what we kind of, this is sort of, was driven home with the people that we spoke to, people really describing how their psychosocial situation was impacting their impulsivity. And the reason that it's exciting is that it opens us up to new ways of dealing with these behaviors. Because in this, we have a number of what are called non-modifiable risk factors. So for instance, I can't change your history or your personality, but there are also a number of modifiable risk factors that we can try and change. The first one is obviously whether you're on a dopamine agonist. And if somebody has a significant impulse control behavior, that is having a true adverse effect, then the best thing for that really is to stop the medication. Now, as I've said, it's a constant balance between risk and benefit, and impulsivity exists on a spectrum. So that may not always be the best thing, but we know that if you want to get rid of the disorder, you probably need to try and stop the medication. However, sometimes we'll keep people on the medication because we balance out that risk. Or sometimes people can't come off their medication because of withdrawal, or some people come off and they still find that they're experiencing impulsive behaviors. So that's why we can look at some of the other modifiable risk factors. And if we can improve your support networks at home, so if caregivers understand what these behaviors are and know what to look out for, and your medical team are more aware, then that will help. And if we can help the way, or if we can change the way you behave, or assist the way you behave in response to a stress, or the way you think in response to stress, then that may be able to break this vicious cycle. Why that's so exciting is that we have therapies that are aimed at sort of developing the way people think and the way people behave, and that's known as cognitive behavioral therapy. Cognitive behavioral therapy is probably the most commonly used psychological therapy. It's incredibly effective in depression and is at least as effective as any antidepressant. And as I've said, it's aimed at teaching new behaviors to deal with stress and adversity. What Dr. Akai is, the neuropsychiatrist at Oxford that I mentioned, what he has done is that he has used cognitive behavioral therapy, or CBT, to treat Parkinsonian impulse control behaviors. And there are 2 studies which are small, but with really, really wonderful results, where he's shown that people who undergo 12 weeks of cognitive behavioral therapy, or 12 sessions rather, at 6 months show an improvement in their PIC score and in some other more standardized measurements of severity. So both they and their caregivers feel that their behaviors are improved. Not only does it improve with the use from before therapy to after therapy, but it also improves compared to a control group. And then that control group were given the therapy again down the line, and we saw the same, they saw the same effects and saw this improvement. And this, I think, is really, really exciting. The reason I think this is so exciting is that it shows the importance of learning about these impulse control behaviors. It would be very easy to just say that Parkinson's is about replacing dopamine. Some of these medications cause impulsivity. If you get impulsivity, you need to stop your medication. The recognition that impulsivity is a spectrum and that can exist in a lot of different ways, and that it can change very quickly over time, shows us, or that it can be even productive in the form of creativity, shows us that it's more complex than that, and that there are other ways to manage these impulse control behaviors. And this can open us up to what is essentially a new therapy for impulsivity in Parkinson's. That's a lot of information. So I'd like to summarize some of the key findings. The important thing is, many people will be familiar with these behaviors, or some people will know some things about it, but not truly understand what they are. It's important to recognize that impulse control behaviors occur as a side effect of a medication. It's usually from dopamine agonists, but it can occur with levodopa, and sometimes it's possible that those 2 things, those 2 medications work together. And they're common. So they occur even in early Parkinson's, at the Oxford Discovery Cohort, we're in a very early cohort of Parkinson's. Everyone was recruited within 3.5 years of their diagnosis, and the average disease duration in that study was, I think, sort of between 5 and 7 years. Not everybody has a true impulse control disorder. You can have an impulse control behavior, or a subsyndromal behavior. And why that's important is that it can still have a significant effect. Because you'll remember, if I just go back for a minute, we looked at the severity in our group. And while this group in the middle, while some of them were a true impulse control disorder, many of them were subsyndromal. Okay, so they didn't tick all the boxes, but actually they were scoring a 4 or a 6 on the PICs. And that means that it is actually having an impact. So just to say that it's not, just because it's not a disorder, doesn't mean it's not significant. And what this means for us in clinic is that if we were to use a tool like the PICs a bit more commonly, then we may be able to have a threshold at which we start thinking, okay, this is now a problem. We need to start thinking about changing medications or changing the way we handle this. The other things to note, the other things that I think our research has shown very clearly is that the severity of an impulse control behavior is not fixed, and it can change very quickly in a short period of time. What that means is that we probably need to, if you are experiencing any form of impulsivity, it's important to keep a very close eye on it, because there's a potential it could get much worse. There's also potential it could get better, and there's also potential it can stay the same. So it's, as long as we are aware of it, and we feel we are adequately balancing that risk and benefit, then I think we can handle these behaviors in clinical practice. Even if you stop your dopamine agonists, and as I've said, that really should still be, if this is a very severe behavior, that should still be the first port of call. Even if you stop your dopamine agonist, you may continue to experience impulsivity. We don't know why that is, but it's a really interesting finding that people kind of go into a subsyndromal state rather than complete remission of their impulsivity. But that doesn't mean it can't be handled, or it doesn't mean that it's even causing a problem. It's just still present. Something that has a huge impact on impulsivity is healthy coping mechanisms and good support networks. So understanding what these behaviors are, having your caregivers understand what these behaviors are, and your clinicians understand what these behaviors are, will go a long way towards helping you manage these conditions. Things that we'd like to look at in the future, and things we'd like other groups to look at in the future, are what the exact significance of a subsyndromal behavior is. How much does it differ from an impulse control disorder? Is there a sort of a pathological difference? And what does it mean over time? Are these likely to become full-blown disorders, or are they going to stay subsyndromal? And the next thing that I think definitely should happen in the future is further trials of psychological therapies, because in future I think we may be able to formalize these psychological supports into cognitive behavioral therapy and other psychological therapies. I absolutely have not done this alone, so I'd like to thank some people who have been real mentors to me at OPDC, and particularly all of the participants in the Oxford Discovery Project, without whom any of this work wouldn't have been possible. And thank you to the Parkinson's Voice Project for having me today. I will take any of your questions.
Okay, thank you, Dr. Kelly. We're going to start the Q&A session. We have a microphone on this side and that side, and if you'll just wait for us to bring you the microphone, and we're going to please hold it close to your mouth. And Dr. Kelly, if you wouldn't mind repeating the question, that will help with everybody watching online.
Yeah.
Do you have any information related to, when I was in Maripex, I wanted to gamble $10,000 on one hand, a blackjack or roll of dice, and I was so infatuated, my wife was saying, well, go ahead and do it. But we never did it, but we mentioned it to one doctor, and he took me off the Maripex. Now I had DBS surgery about 6 months ago. And before that, I interviewed 3 surgeons and a number of neurologists that I've been seeing. And they all recommend putting the probes in a place called the STN. And one doctor said, no, I won't put them there. There's another place he can put it, because he said it could bring back the impulsive gambling by putting them there. So now I got these probes in the ST end. Have you seen any works related to that?
I have read some. So the question is the links between, or if deep brain stimulation can lead to impulsivity. And my experience of deep brain stimulation in Parkinson's, and from what I read, is that on the whole, it's a very useful therapy in avoiding these adverse effects, because it gets people off the dopamine agonist. So on the whole, people's impulsivity does tend to go away if they've had to go on to deep brain stimulation. You're absolutely right that it's almost a theoretical risk, is my understanding, that if you were to put it too close to the reward circuit, you could activate that and cause impulsivity. And my understanding is that there have been cases of it, but it's not very common, but it is certainly something that should be taken into account.
Thank you, first of all, for coming and speaking today. I appreciate it. When you were talking about impulsivity and behaviors, one of the things you mentioned was starting something and not being able to stop. And it makes me think about, for example, Michael J. Fox, who had alcoholism. And what comes first? Is it possible that the PD was there and he may or may not have had alcoholism, but he had PD, and then that caused the impulse behavior?
Yeah, it's a really good question. So basically what I think you're asking is we have this kind of chicken and egg scenario where people can have impulsive behaviors before their diagnosis, and often those can become more of a problem in Parkinson's. The important thing to realize is that all our evidence suggests is that people with Parkinson's are not more likely to be impulsive just from Parkinson's. In fact, because of the level of apathy, and there's belief that there's a sort of a Parkinson's type personality, people are potentially even tend to be less impulsive, though the evidence varies on that. However, problems like alcoholism or gambling all exist in the normal population. So I don't think that you would be more likely to be alcoholic just because you have Parkinson's. However, if you had a history of alcoholism, you were diagnosed with Parkinson's, it would be very important to keep that in mind when deciding on what treatment to go on, because what we do know is that often impulse control behaviors are accentuations of pre-existing behaviors. So like the artists who I showed you were artists before, very often people's hobbies just increase from what they were before. So if you have that history, you will be at risk of further impulsivity or impulse control disorders, but it's not, as far as we know, and it's pretty good evidence, impulsivity is not a consequence of Parkinson's, it's only a consequence of the treatment.
We have a question from Kathy, who's watching online. She says, I experienced impulsivity with Requip. I collected monkeys. Even though my dosage was reduced, I still have the urge to buy more monkeys, but since I know I can't continue the behavior, I have controlled the urge. When I see a stuffed monkey, I get an increased heart rate. Is there anything else I can do to make any feelings go away?
That's really helpful. It's this constant balance. That's a really good illustration of the balance between risk and benefit. It's very difficult to give advice on a situation without sitting down and understanding it. But it's not uncommon for us to hear that people manage to control the impact of their behavior, but while still experiencing the intensity. If that's the case for anyone, what I would suggest is making sure that you keep in very close touch with your Parkinson's team. And I don't know how it works in the US, but in the UK, we are blessed with Parkinson's specialist nurses who have a very close relationship with our patients, who would be able to advise on these sorts of things. If it's truly not having an impact, then that's quite helpful, because it means that we can maybe just monitor that behavior, and it balances out. It balances against the benefit. But just feeling an increased heart rate when you think about these behaviors, to me at least, would actually suggest some kind of impact, and because it's causing distress. And again, the evidence is not completely clear on this, but it seems that reducing your dose probably isn't real. If it really is having an impact, won't make the behavior go away. And it may be necessary to trial off the medications and to use levodopa instead. But that's very specific to the individual, and it would be sort of a discussion with your specialist. Thank you.
Depression play in it? What role did depression play in the analysis of the behaviors?
Yeah, so that's a really, really good question. The question is on the role that depression plays in impulsivity. And the answer is that certainly in some studies, it didn't quite bear true in ours, was that people with low mood and depression are more likely to become impulsive. And that's particularly interesting because it helps to it sort of dispels this myth of dopamine being the happy molecule. What reward seems most often to be driven by is trying to relieve yourself from this low or this dysphoria. It's not that you're seeking a high, or it's actually that you're trying to get away from the low. So that may be why depression increases in risk of impulsivity, not just in Parkinson's, but we know that addictive behaviors increase in depression. And so there's a drive with alcoholism and so on.
Are you aware of any medications other than dopamine agonists across the whole spectrum of diseases that create the same sort of side effects?
Yeah. So the question is whether other medications other than the dopamine agonists cause impulsivity. And the short answer is yes. So levodopa certainly can cause impulsivity. It does it to a lesser extent than dopamine agonists. Where I think that's particularly interesting, and I don't think we know the answer, is if somebody has this side effect as a result of dopamine agonists, are they more likely to have it on levodopa? And I think as we gain more longitudinal data and we can follow this over time, that's something we may be able to look into. But certainly it can occur on levodopa. The other sort of the anticholinergic medications, I've never come off any convincing evidence that it's induced by those. And as I said, with DBS, it tends not to occur. Things like selegiline. Yeah. So and you mean other medications outside of that? Not that I know of. Only illicit drugs, as I said, can obviously increase impulsivity, but I haven't come across them anywhere else.
Here's a question.
I have a question about the disease that comes out of Vietnam, the yellow disease. I got it. I'm just wondering how that's going to affect anybody else down the line.
Parkinson's, you mean, or this one?
He's saying could being in Vietnam have caused Parkinson's?
Oh, he's a veteran, and he was in Vietnam, and he was wondering if the incidence of Parkinson's are you talking about Agent Orange? And is there any connection with the impulse control disorders related to that?
Could you explain Agent Orange?
It was used in Vietnam as an herbicide to kill the foliage, and the soldiers were impacted by it.
Right. Okay. Thank you, because I did not know that. And certainly that's not I've never come across anything to suggest that that would influence risk of impulsivity. I can't think of one either, but I would have to look into it more.
Yeah, the U.S. has recognized that if you were in Vietnam in a certain time when the Agent Orange was used, that you are entitled to certain benefits, and they're saying that could be the cause of Parkinson's. But here's another question.
This is a little unrelated to this part of the conversation, but I got a research report recently from a friend, and I was reading it. It was about the effects of dopamine and extended use and side effects. And it talked about the fact they had found that levels of B6, B12, and folic acid were reduced in the people who were having the effects. Mm-hmm. And I wondered if there's any indication, any research on supplementation using B6, B12, and folic acid to try and get better use out of your dopamine without a side effect.
Is that was that related to impulsivity, or was it dyskinesia?
I think it was dyskinesia. I'm not sure.
Yeah, that's really interesting, and I would have to look that up because I'm not aware of that. But dyskinesia is a very, very different side effect to impulsivity. It's a completely different mechanism of action, and it occurs with levodopa. It tends not to occur with dopamine agonists, which is quite interesting. At least they're very rare. So there's certainly we're looking at therapies out there for dyskinesia. There's only really one on the market at the moment, but that if there was the option of supplementation, that would be really interesting, and I might look that up.
Is it possible, Dr. Kelly, if somebody is experiencing impulse control behaviors on one medication like Mirapex, if they get off that one and on a different one, is it possible, that they wouldn't experience those, or is it all of them?
Yeah, no, that's a really commonly asked question. So if you were to switch from pramipexole to ropinirole, is it going to get rid of your impulsivity? And the answer is, we think probably not. It's been difficult. We think that mostly because people on pramipexole and people on ropinirole are equally likely to become impulsive. They seem to work the same way. There haven't been, that I know of, trials where people were switched, because unfortunately that's quite a risky thing to do, because it may still persist, the behavior. And the medications are so similar on a molecular level that I don't expect that you would really get any benefit from changing. Yeah.
What about apomorphine?
Yes. So
because we tend to talk about dopamine agonists in terms of the other ones you've already mentioned, but apomorphine is also
you're right.
Dopamine agonist.
So apomorphine, I kind of mentioned briefly, is a dopamine agonist. It's been around much longer than the others. In fact, it predates levodopa in existence. But and the question is, does it cause impulsivity? And the short answer is yes. So the first time we started to notice these, that paper on hedonistic homeostatic dysregulation that I described, it was really interesting. All these patients had been on levodopa for a long time. Then as their Parkinson's progressed, they got put on apomorphine, which was in fairly regular use back then. And immediately that led to these addictive behaviors. So apomorphine is a dopamine agonist and absolutely can. The reason we don't talk about it as much is, and I don't know about the States, it's less commonly used nowadays, certainly in the UK. And I've only come, in the discovery cohort, I've only come across one person in this study who was on apomorphine, because it's an early cohort of Parkinson's, so not many use it.
Years ago, before Parkinson's, I was addicted to exercise. Obviously, I'm not now. And I'm wondering why there's not more impulse toward a beneficial activity like exercise.
Unfortunately, dopamine doesn't really discriminate. So if it's going to make you impulsive, it's difficult to decide what you're going to be impulsive in. People do become addicted to exercise. And even as a result of dopamine agonists, but it's not so specific that you can really control that. It may be that you can try and channel your impulsivity, but I don't think we know enough about it yet. But you're right. But even if exercise became excessive enough, it could start to have an adverse impact. But you're right that it's probably less destructive than overeating.
Good morning. I have just a comment. I take a low dose of Mirapex and picked up a hobby that I hadn't done for 10 years. It's not an impulse, but it feels really good. And so I just want to say I think there's benefits to this, and I know a lot of other people with Parkinson's who have similar experiences.
I'm really grateful that you said that. So if anybody didn't hear it, it was that somebody has experienced an increase in a hobby or a new hobby but it's not causing a problem, and there's a lot of benefit to it, and that's absolutely true. And that's one thing we want to that's one thing that this work we're doing we wanted to recognize, because impulsivity definitely exists on a spectrum. As I showed you, it can be productive. It's just important to recognize it when it occurs, so that we're aware of it and it doesn't become a problem. And it may well be, and the honest answer is we don't really know enough about the progression of these things. I've certainly spoken to people who, like yourself, have just experienced an increase in the behavior, and it's stayed there for years, and it's been completely stable and steady, which is brilliant. And so there would be absolutely no reason to change medication in that circumstance. But what we don't really know is there always a risk of this increasing into a more severe behavior? And we can't really lean one way or the other yet. It's just something that we should probably be aware of.
You mentioned cognitive behavioral therapies. Is that something that you would perhaps go through while you've realized that you have an impulsivity and you're trying to control it and perhaps working on medication changes at the same time? Is it an individual therapy, a couples therapy, or both?
So somebody's asking about how CBT works. So there's various different forms of CBT, and in this study it was one-on-one. It's typically one-on-one, but there are group therapies for CBT. And there's also there's all sorts of different ways of accessing CBT. I mean, in the UK we have kind of sort of informal programs or even online programs. None of this would be aimed particularly towards Parkinson's impulsivity, because this is entirely new. But there's certainly no reason that I can think of that you would not, to not use CBT alongside medication changes, because CBT is not a medication. There really isn't much risk and benefit that we're balancing up. There's really only going to be benefit. It may not work, and so it won't work in everybody, but certainly it can have a benefit, and I think it could be used in future.
I have a question, sir. We keep talking about the impulsivity, but what about the apathy? Is there any of these medications that increase the apathy, where you don't have a desire to do things that you really did a lot before you started the medication? And are there any of these medications that cause this to increase?
So the question is whether medication can lead to apathy in Parkinson's. And actually, I'm not sure I know the answer to that question. We do have people in our group who do a lot of research in apathy, and I'm not read up on it well enough. Certainly, apathy can occur simply as a consequence of Parkinson's. I don't know if medications itself can contribute to it. I have a feeling that it can be, but it can be very difficult to tell, because you have to try and discriminate what's the disorder and what's the drug, right? In terms of dopamine agonists, while they don't seem to drive apathy, what they drive is the cycle of impulsivity. So not only do you become impulsive, but in your response to impulsivity, people become low and upset, and it's not quite apathy, because it drives further impulsivity. But it's a really important thing to recognize, is that it's not just impulsivity doesn't just give you a high, it definitely brings about a low, and that's what causes the cycle.
We have time for one more question.
Do you, they caught me off guard. Are you aware of any other research site? This research is brilliantly useful, I find. Do you know of any other research site around the world that is either replicating or have the similar kind of studies as you have at Oxford?
Yes. There's some people who are very, very involved in impulsivity. So the most recent was who looked at the most recent paper that I know of was by Antonini in their group in Italy. And they were again looking at the prevalence and to a certain extent the severity of the behaviours. And then there are also a number of groups in the States, and all the names that I've mentioned on the slides would be worth looking up if you're interested, because Valerie Voon and Daniel Weintraub are among some of the world experts in this area, and their work is really interesting.
Dr. Kelly, thank you so much for being here. Let's give him a round of applause.